I'd like to discuss my topic today, which is radiofrequency ablation compared with conventional surgery for benign thyroid nodules. So as we know, benign thyroid nodules are very common in the adult population, found up to 50 to 60%, of which a large 10% are asymptomatic, causing significant cosmetic or obstructive symptoms to patients. Usually, we treat it using open hemiothyroidectomy under GA, with the benefits of having complete removal and ability to obtain histology. However, it can cause some problems to the patients, as this GA procedure can cause debilitating complications like hypothyroidism, recurrent laryngeal nerve palsy, and unsightly scar. To the healthcare provider, there is a large caseload burden due to the large number of cases and high cost. So RFA, or radiofrequency ablation, has been gaining popularity in the recent years, and the uses a high frequency alternating current to destroy tissues of heat. It has the benefit of being an LA procedure, which is less invasive and has been shown to be quite effective and safe. In fact, in the European Thyroid Ablation Guideline in 2020, it is one of the first-line thermal ablation methods for treatment of benign thyroid nodules. So we first gained the technology approval to do this procedure in 2019, and we started in 2020 in both KEC and NTEC. To the best of our knowledge, we are the first ENT centers in HA with these local data and outcomes, which will show in this perspective review, including 2 centers. So we sought out to answer 2 important clinical questions. Firstly, can we treat benign thyroid nodules effectively with RFA comparable to international standards as ENT surgeons? And secondly, how does it compare with the conventional hemiothyroidectomy? To do so, we followed 50 cases prospectively treated with a single session of RFA from 2020 to this year. We involved 2 centers, both KEC and NTEC. All cases were operated by the head and neck team, who have more than 3 years experience of using ultrasound and had previously completed a radiology master's course. We included single thyroid nodules or dominant nodules of MNG, which were symptomatic and had size more than 2 centimeters in size. They were all confirmed to be benign by FNAC. We excluded asymptomatic cases, those with high-risk features, toxic nodules, retrosternal nodules, and those of bleeding tendency or anticoagulation. To look at the outcomes, we measured both objective and subjective outcomes. For objective outcomes, we measured the volume, we calculated the volume reduction rate, and we look at the complication rate as classified by the Clavian-Dindo classification. Subjectively, we looked at the visual analog scale, including obstructive, cosmetic, pain, and satisfaction score. All cases followed the same protocol. Preoperatively, they had a blood test taken, ultrasound evaluation by radiologists, where the volume was measured. Then they had FNAC done, which confirmed a benign nodule. Then the symptom scores were recorded. Intraoperatively, all cases were done in the LA theater under sedation with no antibiotics given. And post-op, they were all given ice pack, monitored, and discharged on the same day with analgesics. This is just a video showing our setup, which we published in 2021. So this is our OT theater and arrangement of our equipment. Here we show the LA being injected to the thyroid capsule under ultrasound guidance using a 2% lignocaine and 180,000 adrenaline with a 22 gauge spinal needle. Here is the transisthmus approach of the RF probe. So under ultrasound, we ablate the nodule using what we call a moving shot technique. And as you can see on the right side, the nodule is being progressively ablated, where the inferior aspect is tackled first. After that, we progress sequentially to the more superficial part of the nodule to ensure complete ablation of the entire nodule. Keeping in mind the whole time the important anatomy in the ultrasound to avoid injury to the recurrent laryngeal nerve. And here's the machine in real time as the ablation is being done. And here is the ultrasound showing the completely ablated nodule. So afterwards, we follow up the patient, taking the pain score, and then following up them at 2 weeks, 3 months, 6 months, and 1 year. On each follow-up, we measure the nodule volume on ultrasound, and we also record their symptom scores. To analyze the data, we use the mean Wilcoxon-Sirank test and man-weighted test for continuous variables. And for categorical variables, we use the chi-square test. We also tried to see if there are any predictive variables of outcome measures using the multiple regression analysis. And here are our baseline characteristics of our results. Most of our patients are around 50 years old with a female predominance, and the main nodule type was a spongiform nodule. This is the main results of our review. So this is the volume reduction rate with a graph showing different volume reduction rates as sequential follow-ups. As you can see, over time, the volume reduction rate is increasing until the mean volume reduction rate at 1 year is up to 77%. We also have some results preliminarily at 2 years, although not statistically significant yet, but it shows promising 85% volume reduction rate. So we also sought to try to compare with other international studies to see how we're doing. We can see that our results are quite comparable with different groups, around 70 to 80% volume reduction rate at 1 year. These results are also mirrored by the symptom scores. Here we see that the symptom scores of the patients initially and also in sequential follow-up. It is also statistically significant from more than 4 to less than 1 at 1 year for both obstructive and cosmetic symptom scores. So the patients also show a high satisfaction of 9 out of 10 and the mean pain score of 3 out of 10. So this is just some of the examples of our results. This is one patient with a large thyroid nodule in the center, and post-op at 1 year, it is no longer visible, and the patient is also very happy with the symptoms. This is one of our early patients, which shows that the results are still persistent at 2 years follow-up. So to answer the first question, can we as ENT surgeons treat benign thyroid nodules effectively with RFA comparable to international groups? And our answer is yes, we can. It's both effective and comparable. We then sought out to try to compare with hemithyroidectomy. To do so, we compared it with a retrospective cohort in 2017-2021 involving the same centers, matched for age, volume, and gender. We included all cases of hemithyroidectomy with a final benign pathology, excluded malignant cases, remote access cases, retrosternal goiter, toxic nodules, and complicated hemithyroidectomy cases done as part of another surgery. We sought out to compare 3 main variables: the duration of the procedure, the cost to the patient, and the complication rate. We found that there was no significant difference in volume and gender and age. However, the RFA group had a significantly shorter mean procedure time of less than half the time, 43 minutes as opposed to 112 minutes for the hemithyroidectomy cases. Overall, there are no major complications between the 2 groups. However, the complication rate for the RFA group is much lower than the hemithyroidectomy group at 8% as opposed to 37%. The main complications for the RFA group involved transient neck swelling and bruising, and there was one transient vocal cord palsy case, which resolved the next day after a cold saline injection. So this is a photo of the typical hemithyroidectomy case on the left and the RFA case after ablation on the right. As you can see, there's a scar on the hemithyroidectomy case and only a small needle mark, the RFA case. We also tried to compare the cost. To do so, we estimated the cost using the Hospital Authority Gazette cost and also quoted from different insurance companies to try to get a general cost to the patient. We found that overall, the RFA costs less than half of hemithyroidectomy to the patient. So to answer the second question, how does RFA compare with conventional hemithyroidectomy for the treatment of benign thyroid nodules? We found overall it is cheaper to the patient, has a shorter procedure time, and also has a lower complication rate. There are some limitations to our study. It is a small sample size with a relatively short follow-up time, and we did use a retrospective cohort to compare. It'll also be interesting to see longer-term data beyond 1 year to see if there's any nodule regrowth. And in fact, in literature search, there's not much data beyond 5 years post-RFA. So it will be interesting to see how long these results can persist for. Furthermore, there's also constantly expanding indications of RFA for thyroid nodules like toxic nodules, and even for other organs like Wolfram's tumor. Overall, we believe that although it's very effective, it cannot totally replace hemithyroidectomy, as no histology can be obtained with the RFA. To conclude, we have here a prospective study of local data involving 2 centers. We showed that RFA is effective and safe treatment for benign thyroid nodules with a high patient satisfaction and improved symptoms. We also found that as ENT surgeons, we can produce data that's comparable to reported international results. And we found that compared to hemithyroidectomy, it is a lower cost to patient, shorter procedure time, and has a lower complication rate. And very importantly to the patient and to us, it can be done under LA as a day case. I'd like to give special thanks to my colleagues, Dr. Lau and Dr. Young, for their assistance and mentorship. And I'd like to thank you all for your kind attention and welcome any questions. Thank you.